welcoming. Assalamu alaikum wa rahmatullahi wa barakatuh. Dear our guests, our friends, colleagues from Middle East and across the world. It's an honor today that I'm chairing or the co-chair with Professor Victor in this meeting. It's beginning of 2023, and it's so excited year that we are starting again after more than 24 webinars that we have over the last 2 years. It was a success journey for the last 2 years. MENASO Grand Round is one of the largest education academy for cerebrovascular series across the Middle East, and I would like to thank our partner during this journey, starting with the American Heart Association, Pan-Arab for Neuroscience Society, the World Stroke Organization, and also Sheikh Khalifa Stroke Institute, Johns Hopkins Medicine. This year, we will have a total of 12 update webinars in the cerebrovascular and stroke field, and I'm sure that all of you are excited with the update things coming in this field. No further delay, as a great number of attendees is attending today our webinar. I would like to remind all our attendees that by the end of today's webinar, there will be 20 minutes for the question and answer, where you can use the Q&A bar to send all your questions there. Today, we have a distinguished chair and speakers, a part of our collaboration with Sheikh Khalifa Stroke Institute, with Professor Victor Urrutia. We are happy that we are having Johns Hopkins today with us for this meeting. Professor Victor is a professor of clinical neurology at Johns Hopkins University School of Medicine. At the same time, he's the director of Sheikh Khalifa Stroke Institute and the director of the Comprehensive Center at the Johns Hopkins Hospital. He's the medical director with Johns Hopkins Medicine International and the founder and the director of the Global Center for Organized Stroke Care. With no further delay, I would like to ask Dr. Victor to welcome our speakers for tonight.
Thank you, Professor Alrukn, and I am delighted to be here, and that Sheikh Khalifa Stroke Institute is endorsing and supporting the MENASO webinar series, and especially with this first webinar this year. I'm going to, in the interest of time, I'm going to jump in and welcome our speakers, which are Dr. Mona Bahouth, who's going to be speaking about early stroke recovery at the stroke unit, and Dr. Preeti Raghavan, who's going to be speaking about stroke recovery interventions. And I'm going to proceed to introduce Dr. Mona Bahouth so she can start her talk. Mona Bahouth is the medical director of the Brain Rescue Unit at Johns Hopkins Hospital and an assistant professor in the Department of Neurology. Her clinical and research interests focus on the physiologic determinants of early stroke recovery. She hopes to translate this evolving knowledge into the care delivery system in order to improve both clinical outcome and patient experience within the very early period after stroke. Dr. Bahouth obtained her medical degree from the University of Maryland School of Medicine and completed a neurology residency and the cerebrovascular fellowship at the Johns Hopkins School of Medicine. She also has a PhD from Johns Hopkins School of Public Health in the Science of Clinical Investigation program. Her prior work has focused on system development and the integration of creative technologies for patient care during the hyperacute period of stroke treatment. Combining technology and innovative approaches to early stroke care and research, her team hopes to transform the early comprehensive health systems and remove the mark of stroke across the globe. So without further ado, Dr. Mona Bahouth is going to start her topic. Welcome, Mona.
Hello, everyone. Thank you to the conference organizers, and thank you, Dr. Urrutia, for that kind introduction. Let me go ahead and share my slides. I'm hoping you can see this in presenter mode.
Doctor, we can see the other window, not the full screen view.
Okay, hold on 1 second.
Sure, doctor.
Okay, I'm hoping this is
Perfect.
better. Okay,
Perfect,
wonderful.
doctor. You can start. Thank you.
Wonderful. Well, good day, everyone. And thank you for being here with us. I'm very excited to join you from across the globe on this exciting day to talk about a topic that is dear to all of our hearts. Again, I am going to focus today on the very early stroke recovery period, how we use our system of stroke care to improve patient outcomes. I don't have any relevant disclosures, but listed here are my funding sources. In way of brief outline, we'll start with a bit of a background about stroke and why this topic is important. We'll touch on a couple of physiological concepts that drive our early stroke recovery care. And then we'll talk about creative ways that we've been using the stroke unit and enriching the stroke unit to focus on early recovery for this patient with stroke. So I'd just like to start by saying that we've made tremendous gains globally on our stroke care, such that patients are surviving much more often after stroke than ever before. You can see by this global map provided by the World Health Organization that many countries are achieving very low mortality after stroke, so much so that stroke is moving down on the list of leading causes of death globally. But you can see that there are many areas of the world that continue with very high mortality related to stroke itself. We know that this improvement in mortality has come from a couple of different sources. One is that we are working to save the brain by offering more revascularization therapies, such as thrombolytic therapies or revascularization thrombectomy, both surgery and medications. And those are reaching more and more patients with every passing day. We also know that the development of stroke units that have standardized approaches to stroke care have very significant opportunities for improvement to reduce both death and dependency for patients, as well as to improve outcome after stroke. And a stroke unit can be defined as a specialized group of doctors, nurses, and interprofessional team members like therapists to standardize protocols and avoid complications after stroke. And you can see here from this slide that even just having a stroke unit by itself achieves a number needed to treat very similar to TPA and thrombolytic therapy. But I would still say that we have so much to do. And the reason is this: still, we have 15 million people per year having stroke. We can do a lot more to reduce the onset of stroke in the first place. But the most compelling statistic for me is that it remains the leading cause of adult disability, meaning patients who are experiencing stroke do not achieve the quality of life that they hope for, and they have both reduced function and capacity after their stroke. This is for patients even with mild stroke, those patients with NIH stroke scale scores less than 5. Those patients still report in some studies that their 3-month functional outcomes are poor. And we know that stroke is not only a burden for the patient in terms of their disability, but lost productivity for the caregiver and high economic burden for countries. So still much work to do here, and thus the thrust of our conversation today. So just to be sure we're all together on the portion of stroke care that we're going to talk about over these next few minutes, we know that stroke is a continuum of care. from the onset in terms of stroke prevention, all the way through to the chronic period of phase where patients are living for years with their stroke-related disabilities. But I would want to say that for our next few minutes together, we're going to focus on the early recovery period, this time highlighted by the red arrow. And I would hope that each of us will ask ourselves during this conversation, are we optimizing the patient's clinical status? Are we doing everything we can to help the patient recover from their stroke and reduce their longer-term disability? Now, there are a lot of animal studies that really drive us to understand that this is a very critical period after stroke. I really like to focus on it because I think it might have the highest reward if we get things right during this time period. A study by Dale Corbett and colleagues really demonstrated that there is a critical period where the brain has its highest chance of healing, the chance of highest brain repair in the first 14 days after stroke. During this period in animal models, we know that there is upregulation of growth promoting factors, things that will help the brain to repair, and inhibition of growth inhibiting factors, things that will kind of block the brain from repairing. So to me, this first 14 to 30 days is a critical period for us to get exactly the right treatments delivered to the patient at exactly the times that they need in order to get them the best benefit for long-term outcome. And we also know that if we can avoid complications, we can really reduce chance for long-term complications and increase disability. In the study by Rauter and colleagues in 2015, they really highlighted this graphic that really tells the story really well to me. If you are to get any of these complications common to stroke in the first 7 days after the stroke has occurred, you will really reduce your chance of meaningful recovery after stroke. For example, if a patient were to get a chest infection in the first 7 days after stroke, they have an increased odds of having a very severe modified Rankin score, greater than 3, meaning highly dependent on someone else, nearly 3 times increased odds of having a worse outcome if they were to develop this complication. You can see that there are other things. If a patient has a recurrent stroke, they have 10 times the odds of modified Rankin greater than 3, meaning high rates of disability. And this really tells us that our focused care in the first few days after stroke should really be focused on both reducing complications and promoting meaningful activities that help with brain repair. One study that translated this to humans really was the CPAS study by Dromrick and colleagues. This study was published in 2021 and really underscored for us that increasing meaningful activity for patients within the hyperacute period, within the first few weeks after stroke, had meaningful gains for the patient to promote outcome. In this study, patients received 20 additional hours of upper extremity motor training. It provided the enrollment periods of the acute phase, subacute, chronic, and against a control group. For this study, they enrolled 72 patients. It was a phase 2 study. And the key here is that in both acute and subacute phases, they noted meaningful outcomes for patients in terms of upper extremity motor recovery. So suggesting that these are really the periods ripe for patient recovery if we were to prescribe meaningful intensive therapy. And we also know that the recommendations from the American Heart Association suggest that it is recommended that stroke survivors receive rehabilitation at an intensity commensurate with anticipated benefit and tolerance. So this is really a suggestion that while the patient is in the hospital, we should begin restorative therapies for patients. That sounds easy when put into a guideline, but it's not as easy when you try to translate that into clinical practice. We know that patients in the hospital, unfortunately, are not moving very much. They're isolated and they're alone in their rooms. Even in some of the highest systems of stroke care, patients are bedbound more often. They have reduced activity because of both paralysis and cognitive disturbance. And we know that bed rest is complicating many of their medical conditions. So patients really are not moving as we suspect that they should be moving in those first few hospital days after stroke. One study, one of the best multi-center studies, looked at very early mobilization as an intervention to try to get patients up and going. The AVERT-2 trial by Bernhardt and colleagues was one of the largest international multi-center trials enrolling 2,000 patients to look at very early mobilization versus a control group of standard care. And what they found was that patients who received very early mobilization actually demonstrated a reduced odds of good functional outcome. This suggested to people that perhaps it wasn't as easy as we thought to just get patients up and moving as an intervention that would help them recover, and placed questions upon whether or not we should get patients up and moving quickly within the first 24 hours of care after stroke. There were a couple of key features, though, that made this study very difficult to interpret and translate into practice. First, the control group drifted towards the very early intervention group, meaning that the control group actually began very early mobilization on the order of 19 to 20 hours after stroke onset. We also know that the duration of out-of-bed sessions varied greatly, and subgroup analyses suggested that patients with shorter duration out of bed did better than those with longer sessions. But the most worrisome issue was that there was a large change in blood pressures for patients in the intervention group. Those who were mobilized very early after stroke demonstrated a very large change in blood pressure swing, meaning that there was a physiologic difference between the two groups. This is very important for a couple of reasons. And this physiologic concept is really one that drives our care in the very early period after stroke quite closely. We know that blood pressure matters for stroke patients. We know that after stroke, autoregulation, the protective mechanism for the brain after stroke, has been disrupted. And in this graphic, it really gives us a nice picture of the difference between patients who have their autoregulation intact and those with stroke who have had autoregulation disrupted. If we look at the graph here, on the y-axis, there is cerebral blood flow to the brain. On the x-axis, we see mean arterial pressure. The solid line demonstrates patients with intact autoregulation. You can see for a wide range of blood pressures, 70 to 120, the blood flow to the brain is fairly constant. Only when we reach extreme ends of blood pressure control does our cerebral blood flow change in the brain, and at a very gradual pace. So if you have very low blood pressure, you have disrupted cerebral blood flow, but not to the degree as when autoregulation is disrupted. You see here the dotted line, that is when autoregulation is impaired. For example, patients with stroke in the first couple of weeks. The line is very straight, meaning that your brain sees exactly the blood pressure that your body is delivering. You no longer get this protection through vasodilation or vasoconstriction. And therefore, any blood pressure that the patient achieves through medication adjustment or changes in blood pressure will disrupt the cerebral blood flow directly. And when this happens, you can have a couple of complicating features. When you don't have autoregulation to protect you and your blood pressure goes high, we have increased cerebral edema and increased chance of hemorrhagic transformation. When the blood pressure goes low, lower than your brain's threshold for cerebral perfusion, we can get secondary cerebral ischemia and infarction. All of this contributing to poor secondary outcome and complications after stroke. Therefore, when we think about early activity in the hospital period after stroke, we really need to keep blood pressure at a top priority. And additionally, to the blood pressure issue, when we think about all the challenges to getting patients moving for therapeutic activity after stroke, we need to consider a couple of other features. One is that the patient is hemiplegic, meaning that they may have high challenges to staff to move from the patient's bed into an active state. We see risks to the patient and staff injury. Again, we talk about blood pressure lability. 60% of patients have dysautonomia, meaning their blood pressures, even on a normal day, might fluctuate with orthostatic hypotension. And we know that nearly half of stroke patients are dehydrated. These blood pressure fluctuations lead to stroke extension based on cerebral perfusion. We also know that this population of patients having stroke are frail at baseline. They often come in with cardiovascular deconditioning and are intolerant to aerobic activity. Therefore, we need to really pay attention to the tolerance of the patient for activity levels. And the next three items are things very common to stroke patients: early fatigue, meaning very hard to get the energy for some of the intensive therapies that we're attempting to prescribe. We know that patients are a fall risk, and therefore using therapeutic tools to make sure that patients are safe are paramount. And we know that patients' cognitive status don't often promote concentration on prescribed tasks. So taken together, all of these things really can make it challenging for your teams to get patients moving for therapeutic activity in the early stroke period. So our solutions are the following. We really believed in establishing protocols for progressive activity. We know from the AVERT trial that going from bed rest to standing did not appear to be the right activity. Therefore, we want to have algorithms that titrate this activity for the patient. We want to make sure that the patient has the right support to both monitor and perform the activities that we are prescribing. We want to try to find therapeutic activities that are motivating, that really engage the patient who's both fatigued and has poor attention. We want to make sure that the physiologic variables that are important in the early period are monitored, and that we modify our treatment therapies based on the patient's response to our prescribed interventions. So here we started with an algorithm that really focused several years on how to get all staff members to progress a patient's activity level from bed rest to more upright position very gradually over time. This is an example of our algorithm that we put into place in our neuro ICU, place where the patients were most critically ill. We wanted to make sure that the algorithm was applied to most patients unless unsafe with spinal instability. And here again, we use a very progressive approach where we go step by step to really get the patient from a laying position towards a walking position over time. The idea is that all staff members can get involved in between therapy sessions to really progress the patient's activity level. And this came with stopping rules that really taught staff how to monitor the patient closely. And if we had any changes in neurologic status or safety, that the patient would go back to one level below in terms of activity. When we put this activity protocol into place in our ICU without any additional staffing, we found increased odds of mobilization. We reduced our time to first mobilization in patients with intracerebral hemorrhage by 1 whole day. We increased the number of times that patients were mobilized daily by 3 to 4-fold. And this was actually without increasing physical therapy or occupational therapy staffing. We did this in a budget neutral position. So some benefits, both safety-wise and through staffing, to really increase early activity with an algorithm that was prescribed for stroke patients. Next, we looked to make sure we had the right tools available to our staff and to our patients to work into this progressive verticalization algorithm that we had. We didn't want patients to go from laying in bed to standing up. So we bought a few key tools that have been important for our patients. Some of them look fancier than they are. This one in the center here is a tilt table, meaning it can advance a patient from a laying position to a standing position slowly over time. And then the other main tool that we use is a cycle ergometer, a bike that can be used for patients in bed and out of bed to really promote muscle movements, even if patients are comatose. So all these tools together really assured that our patients were safe and our staff were safe as they contemplated increasing early activity for hospital patients. We created algorithms to make our cycle ergometer into an upper extremity tool. And again, here we were looking at physiologic parameters to be sure that nothing changed in terms of blood pressure, heart rate, or intracranial pressure. So in this study, we took a series of patients with ICP monitors, intracranial pressure monitors, to be sure that patients enrolled in this algorithm really demonstrated hemodynamic and intracranial pressure stability. All ended up being safe for the patients, even in the very early period in the ICU. Next, excuse me. Next, with our physical therapy, occupational therapy, physiatry team, we came together to create an enhanced stroke therapy model. We really realized that our patients were in bed, not receiving much therapy in the very early phases alone. And here we proposed that we would bring nearly 3 hours of 2 to 3 hours of therapy to patients in the hospital, beginning right during the first couple of days after their stroke. This joint effort really resulted in a lot of great outcomes in terms of our staff working together to get patients up and out of bed. Patients are now achieving 2 hours of therapy in addition to their diagnostic testing and usual care. And we're seeing hints that length of stay is slightly reduced, and our 3-month modified Rankin scores have shown some hint that there is improvement when we have an early therapy model brought into hospital patients. This is all conducted with some advanced physiologic tracking. So for a period of time, we wanted to see if monitoring hemodynamic status of patients from afar, meaning the neurologist or nurses could monitor a patient's hemodynamic status during some of these therapeutic sessions. During this period of time, we used various devices to look to see if while the patient was undergoing activity, we could detect any change in hemodynamic status. We looked at cardiac output for changes, as well as changes in blood pressure, oxygen status, and heart rate. We then began on a mission to really increase our patients' activity. Excuse me for 1 minute. Had a small cold. We then set on a path to increase patient activity that would be motivating and entertaining. Here we together created a program where all of our staff together donated their video game systems from home, their Wii systems that they had purchased at home for their children years ago. We created an algorithm that looked to see if patients had particular stroke deficits, balance problems, coordination problems, cognition issues, neglect. Could there be certain games that might promote healing and recovery from that we could have patients play even in their own time, day or night? This algorithm was tested both in the ICU and the intermediate care unit for patients, and we found that patients really engaged well with these games and increased their time of meaningful activity. Using this Wii algorithm, nursing staff really increased patients' access to the game. We only had one safety issue where a patient's blood pressure dropped below target, done with every 5-minute checks that we were conducting during this study. And we found that patients achieved 32 extra minutes of activity above and beyond their therapy sessions that they were receiving in the stroke unit. Next, we have teamed up with our CATA group, who are our biomedical engineering group, who create digital therapeutic games that are really immersive experiences for the patient. Here we have initiated a protocol where we are trying to achieve 60 minutes additional time on task for patients, meaning 60 minutes of high intensity, meaningful activity for patients while they're in the hospital unit several days after stroke. Thus far, we have most patients are achieving 30 continuous minutes of extra upper extremity time on task within these immersive treatment rooms where the patient goes and senses that they're away from the hospital space altogether, using this immersive experience. There have been no safety issues for patients using this technology, and we've been developing additional games to really focus on both hand and upper extremity, as well as aerobic treatments for the patients. This is just another picture of the immersive room. On this side of the screen, if you can see my arrow, this is the place where the patient comes into a game sort of away from their hospital space. They come in there for a 1-hour session at a time. And over here is our in-room treatment space that we've been building to really test to see if patients will be self-motivated to conduct additional therapy sessions using this video game therapy and this neuroanimation therapy to motivate them to improve their upper extremity motion. So far, patients are enjoying it. We've really had a lot of success in terms of both time on task, as well as the ability to hone our protocol for increasing use into multi-center trials. And then I want to end with a few other additional things that we've done in our space to really enhance the environment. How can we make our stroke unit from a more diagnostic space to a healing space? So in addition to our video game treatment rooms, we've created additional socialization spaces. Here we started a communal eating program for our patients. Excuse me. This was a study performed to see if patients who were moved out of their rooms to eat lunch together, if that would promote both increased language production as well as increased PO intake. Pardon me. So through this study, these patients were brought out of their room for several sessions. For patients who went out of the room for more than 2 eating sessions, they increased their PO intake by 65%, and they increased the amount of language production that they had in 39-minute sessions. These were observed spaces where people could eat together with both their loved ones as well as a staff member and other patients to really reduce that sense of isolation after a stroke. Next, with our Peabody Institute and a grant, we really wanted to see if bringing live music to our stroke unit could have any benefit to both healing, patient mood, as well as blood pressure recovery. And we have started a small project that had to be abruptly ended due to COVID, but we looked to see if hemodynamics would change at all with live music for the stroke patient. So far, so good. This is in its beginning phases, but we found that patients' moods have increased and patient verbalized feelings that they weren't in a hospital at all and that they feel that they're healing instead of just in a hospital space. So more to come on that. And then finally, we want to make sure that all of the interventions that we begin in the hospital are translated to the patient when they leave the hospital. We don't want things that are very positive for the patient in our stroke unit to just end when a patient goes home. And we know that about 50% of our patients go directly home after the hospital. Therefore, we started our post-hospital transition clinic. This is a clinic where we monitor patients closely after they leave the hospital. In the first phase of this program, we attempted to have a visit within the first 7 days with a neurologist and a physical therapist combined. The second visit during this phase of testing was with a physiatrist and an occupational therapist. And then the third visit was in an immersive education session with our dietitian, as well as therapists, nurses, and physicians. Here, we thought we would be able to reduce hospital readmissions and really promote access to physical therapy very early after patients left the hospital. And we did really show increase in terms of our patient follow-up. Patients were seen much sooner than in standard care hospitals. And we showed that patients could achieve this using a telemedicine link to their house. With very high show rates, 86% of patients achieved all their first visits, and physical therapy visits were accelerated tremendously compared with standard care. So what starts at our stroke unit continues at home, and we hope that this program will continue to have high success for patients there. So in summary, time is very critical for stroke management. We believe in starting restorative treatments earlier when the brain has its highest chance of healing. Specialized stroke care with attention to patient activity in the first days after stroke will help us reduce complications. I do believe that early activity should be guided by physiologic responses to assure patient safety and the benefit to patients. And as a team, globally, we won't stop until we eliminate stroke-related disability. And I'm so thankful that we have conferences like this where we can continue the conversation together to be sure that we're helping every stroke patient to achieve their highest level of recovery. Here are some references that I can share, and I want to say that this sort of effort could not be possible without a tremendous team, and I'm really lucky to work with one of the best teams. We have many, many people coming together to think of these problems in very creative ways, so I really appreciate the team member that came together for all of this work that I presented today. Thank you so much for your attention. Here is my email address for future contact, but I look forward to discussion in our discussion period. Thank you.
Great, great talk. Thank you, Dr. Bahouth. In the interest of time, I'm going to go ahead and introduce our next speaker, Dr. Preeti Raghavan. Dr. Raghavan is going to be speaking about stroke recovery interventions. She is an associate professor of physical medicine and rehabilitation and neurology. She serves as director of the Center for Excellence in Stroke Recovery and Rehabilitation at the Sheikh Khalifa Stroke Institute, and is the vice chair for research in physical medicine and rehabilitation department at Johns Hopkins. Dr. Raghavan is recognized internationally for her groundbreaking work on the treatment of muscle stiffness, which is transforming the way we treat neurologic disability, and her cross-disciplinary innovation, which has led to worldwide patents and for the development of new technologies and treatments for the recovery of movement in individuals with stroke. She has made tremendous impact in reorganized stroke rehabilitation to facilitate early recovery and bridge the continuum of care. She recently edited a textbook, Spasticity and Muscle Stiffness, Restoring Form and Function, published by Springer Nature in 2022. So without any further ado, Dr. Preeti Raghavan. Welcome, Preeti.
Good evening, and thank you so much for that kind introduction, Dr. Urrutia. It's a pleasure to have the opportunity to speak to all of you at the MENASO Education Academy. I'm going to share my screen. Could you see my screen all right?
Yes, doctor. Can you make it full screen?
It should be full screen. Do you not see full screen?
No, doctor. This is the other kind of view. You can stop sharing and share again. But before you share, make it full screen. Then select the full screen view.
Okay.
Yeah, you can stop sharing now and make the PPT full screen. Then share again by selecting the full screen view.
Okay. Can you see it now?
Yes, we can see the presentation, but it's not in the full screen
It's
mode.
not yet full screen. Okay.
Yeah,
Give me a second.
when you're, no problem, doctor.
How about now?
Yes, it's okay, I think.
Is this good?
Yeah, that's perfect.
Yes, doctor. Now it's full screen. You can begin.
Okay, perfect. Thank you so much for your patience. It's a pleasure to talk about stroke recovery interventions today. Before I begin, I'd like to disclose that I am the co-founder of Movies Inc., and I will discuss the off-label use of hyaluronidase for muscle stiffness. Okay. So the objectives are to describe the role of muscle plasticity in neurorehabilitation and the basis of the treatment of muscle stiffness with the enzyme hyaluronidase to facilitate neurologic recovery. a lot of the work that I'm going to describe really began in my research lab, the Motor Recovery Research Lab, where the goal was to study what the barriers are to recovery of arm and hand function. So we used motion analysis, we used EMG, and we were really trying to understand, where is the critical problem? Is it that the brain is not able to reorganize? Is it that there is a problem in terms of the way the muscles respond to the signals from the brain? And what we have found, and what's beautifully summarized in this paper by Sherbakov, is that the skeletal muscle is the main organ of disability post-stroke. So although the problem begins neurologically, the skeletal muscles adapt to the lack of movement. And, in line with what Dr. Bahouth just presented, reducing the complications of immobility through early mobilization is critical. When people are immobile, it promotes lack of use or non-use, and that leads to changes in the muscles. For example, muscle shortening and stiffness, leading to a reduction in range of motion and a further reduction in strength. And so when the patient does try to move, they tend to use more muscles than are necessary in the ordinary case, leading to abnormal movements. And because the movements are abnormal, those movements are reinforced during therapy, and it leads to a vicious cycle of non-use, bad use, reinforcing non-use. And so the changes in muscles are really important to prevent through early mobilization and early rehabilitation, as Dr. Bahouth so eloquently described. If we do that, we can convert this vicious cycle of lack of movement and abnormal movement to a virtuous cycle where you have a greater opportunity for movement and perhaps greater translation to function to disrupt that cycle of disability. Now, muscle stiffness is a key intermediary problem, and we notice this very frequently in our patients who have chronic stroke. So at the beginning, you might notice that there's just tight muscles at rest, making it difficult for the person to initiate the movement. Perhaps there is input into the muscles. However, the muscles are so stiff that they are not able to manifest any of that input into real movement. Other patients might demonstrate muscle tightness due to activity, making it difficult to control their movements. And therefore, when they try to repeat movements, that is difficult. In some patients, they may try to move in one direction, but it may lead to movement in the opposite direction. And many patients have difficulty relaxing or stretching their muscles, or they may have pain on movement leading due to the stiff muscles. So what really causes muscle stiffness? We're all familiar with hyperreflexia and spasticity, and it is thought that the real reason for spasticity is that the stretch reflexes are overactive. You all know the stretch reflex pathway, but I'm just going to very quickly go over it. So when a muscle is stretched, that stretch is sensed by your afferent fibers, and which synapse with the efferent fibers, both the gamma and the alpha. And they respond by leading to muscle contraction. We see this every day when we test the reflexes. But after a stroke or after a neurological injury, we know that there is an imbalance in the descending input, and so there is lack of suppression of the stretch reflexes that normally occurs during activity. And therefore, the thought is that there is muscle overactivity. Now, all of our treatments are designed to suppress this muscle overactivity. For example, we may disrupt afferent input by doing a dorsal rhizotomy, which is common in children. In adults, we may give intrathecal baclofen, we may give CNS suppressants, that is to reduce the excitatory descending input on the efferent fibers that lead to muscle activation. The problem with that is that it can also lead to muscle weakness. Similarly, we can give nerve blocks, which may also lead to muscle weakness, or we may give botulinum toxin injections to target specific muscles, also causing additional weakness. Now, the problem with any treatment that causes weakness or sedation is that it's suboptimal and it can further lead to increased loss of movement. In fact, here is some data from Fortuna et al., where they looked at rabbits who had gotten just one episode of Botox injection, and they compared it with the contralateral muscle on the other side, so the unaffected or the uninjected side. And what you can see is that clearly there was a change in the muscles. There was loss of active muscle fiber at 0 months when the Botox was given on the injected side. But notice there's also some loss of muscle on the contralateral non-injected side. Now, if you follow the animal at 1 month, 3 months, and even at 6 months, you see that there's still persistent loss of muscle even at 6 months. And it is predominantly on the injected side, but you also see some of it on the non-injected contralateral side. If you give multiple injections at 3-month intervals, which is the way we do it in humans, you see that these changes in the muscles remain constant. You're losing viable muscle. So another study by Kairi et al. Looked at what types of changes occur in the muscles when you unload them. Now, unloading can occur because of immobility, paresis, and or Botox. And when you do that, what you see in the Botox injected muscles, which are shown here in red, relative to the untreated muscles, you see that there is a shift in force, so reduced force. There's reduced displacement, so the red line is lower, and there is an increase in stiffness. That's what you see in these bars. And when they looked more closely at the changes in the architecture of the muscle, they found increased collagen content and some increased proteoglycan content. These were not significant, but the collagen content was significant. So this data, as well as others, prompted us to take a closer look at muscle architecture. And what you see is that the muscles, whole muscle bundles, the whole muscle itself is wrapped by a layer of collagen called the epimysium. The muscle bundles are wrapped by perimysium, and each muscle fiber is wrapped by endomysium. These constitute the extracellular matrix. But in addition to the endomysium, perimysium, and epimysium, you have the loose connective tissue, which has your fibroblasts in them. You have blood vessels here, you have lymph vessels, the nerves come in here, but you also have glycosaminoglycans. For example, hyaluronic acid. So what is hyaluronic acid? Hyaluronic acid is a sugar molecule, a glycosaminoglycan, that is non-sulfated, and it is present in every single tissue of our body. In the muscle, here it's stained brown. So all this brown staining that you see in the top slide is hyaluronic acid. And you can see it's right around the collagen structures that I just talked about. The endomysium, it's in the perimysium, the space with the asterisks, and it's also in the epimysium at the edge of the muscle. And we know that it is hyaluronic acid because hyaluronidase was then used to treat these slides, and you see that all the hyaluronic acid was washed out. So all the brown stuff is gone. So hyaluronan is actually produced in the muscle by enzymes called hyaluronic acid synthases, and then it is extruded in the extracellular space. And it is what is right between two adjacent muscle fibers. Now, hyaluronic acid can form very large polymers, which can then bind to each other loosely. And what happens is hyaluronic acid is synthesized in the muscle because it functions as a lubricant in normal concentrations. It facilitates sliding between muscle fibers and facilitates force transmission during movement. So just to illustrate this, here's a model of two muscle fibers. And when there is movement, they slide against each other fairly easily because of this thin layer of lubricant. However, when there's too much hyaluronic acid, it actually binds to itself and becomes of very large molecular weight. And that leads to further aggregation of hyaluronic acid, which increases the viscosity of the extracellular matrix and leads to decreased lubrication and tissue sliding. It's been found that as the concentration of hyaluronic acid increases, there is an exponential increase in the viscosity of the fluid. And when the hyaluronic acid becomes highly viscous, it also self-aggregates to form highly structured molecules, which almost are solid in consistency. So this is just an example of that. And so you can imagine that if we look at our model again with now this thick, almost solid layer of hyaluronic acid between the muscles, then during movement, there's just not enough sliding between these muscle fibers. The muscle fibers are literally stuck to one another, and there is resistance to movement. A patient might complain that the muscle is stiff. There's increased resistance to passive movement, and you may need to generate more force to lead to the same amount of movement as before the hyaluronic acid became so solid. And so now muscle overactivity can also be a consequence of the stickiness. Furthermore, as I shared with you, the nerves enter the muscle in the perimysium. In the perimysium, we also have the muscle spindles. Now, you can see the same structures on the right side of the slide, stained with toluidine blue, and on the left side, we are staining the same section with hyaluronic acid binding protein. So all the brown that you see is hyaluronic acid binding protein and binding to the hyaluronic acid. And what you're seeing is that the muscle spindle, which is shown here on the extreme left, is also composed of a lot of hyaluronic acid. All this brown stuff is the periaxial space of the muscle spindle, which is full of hyaluronic acid. And in fact, this sugar molecule is responsible for the stiffness of the muscle spindle itself, which then can change the afferent activity that's going into the spinal cord for regulation of the stretch reflexes. So in other words, increased hyaluronic acid in the muscle, in the perimysium, can also increase the muscle spindle's sensitivity to stretch. So we came up with the hyaluronan hypothesis of muscle stiffness, where paresis and immobility, as well as muscle overactivity and some types of overuse where you're repeatedly using the same muscle over and over again because you don't have enough flexibility in movement, can lead to increased production of hyaluronic acid, as well as decreased degradation of hyaluronic acid because it has become aggregated. And this then can lead to hyaluronan accumulation, which may be reversible, and I'm going to talk to you about that quickly. Whereas if you don't treat it, it can become irreversible, leading eventually to muscle fibrosis and contracture. This is something we typically see in younger people, let's say with cerebral palsy, but we can also see it in patients with stroke if they are untreated for a very long time and they are immobile. So let me share with you some evidence on how immobility increases hyaluronic acid accumulation. This was a rat study done in 2003 where they immobilized the rat ankle joint, and compared to panel A, in panel B, you see there's a lot more brown, and that is due to the hyaluronic acid accumulation. It was washed out with the enzyme hyaluronidase, but when they looked at scanning electron micrographs of the muscle, they found that 12 weeks after immobilization, you see that the endomysia are all matted together, right? So at 4 weeks after immobilization, you saw the hyaluronic acid accumulation, but at 12 weeks later, at 12 weeks after, you're actually seeing structural changes. Now, we are able to image the hyaluronic acid concentration in humans using a special type of MRI technique called T1-RO. On the top panel, you see the hyaluronic acid concentration in a control upper arm muscle. So you're seeing the biceps and the triceps, and you see the relative circular shape of the arm. In the middle panel, you're actually looking at the same upper arm of an individual with stroke who's extremely stiff. And you see that there's a lot of red that represents the glycosaminoglycan concentration or the hyaluronic acid concentration. And you see that the shape of the muscle is triangular. It looks like it's all stuck together. In the bottom panel, we treated the muscles with hyaluronidase, the enzyme that breaks down this accumulated hyaluronic acid. And you can see that all the red is almost washed out and the shape of the arm is restored. It's circular once again. Now let me share with you some evidence on how muscle overactivity can lead to increased hyaluronic acid. So this was another mouse study where they actually transected the soleus muscle and looked at the plantaris muscle, which compensates for the soleus muscle. And you can see that 2 days post Achilles tendinectomy, you see increased red. Now this red is hyaluronic acid binding protein on this slide. And you can see that this is a freely moving mouse. So there is increased production at 2 days. At 7 days, it reduces. At 14 days, it reduces even more. But this just illustrates that really at 2 days, there's increased production. Now, the real problem sets in when you have some kind of overactivity, maybe because of spasticity, and you have paresis or immobility. This just shows you that the same MRI technique can show you the changes even after overuse injury. And this slide shows you that when hyaluronan concentrations increase, that's when the fibroblasts are converted into myofibroblasts that are eventually responsible for fibrosis of the muscle. So we can potentially break the cycle by breaking down the excess hyaluronan or degrading it. How can we degrade hyaluronan? Well, in vivo, in the human or in the body, the hyaluronic acid has to either be extruded into the serum during mobilization or during exercise, or it has to be taken back into the muscle and destroyed by endoglycosidases inside the lysozyme, right? So there are endogenous hyaluronidases which do this. However, the hyaluronic acid from the extracellular space has to be broken down to go back into the muscle. When that doesn't happen, then the hyaluronic acid just accumulates. So we found that there is a human recombinant hyaluronidase that is commercially available in the United States, and it is FDA approved since 2005. So we wondered if we could inject it into the muscles, and perhaps that could break this whole cycle of paresis, stiffness, and all the complications that lead to disability. So this was our very first study that we published in 2016, where at T0, you're seeing the baseline situation where more than 50% of the joints showed a modified Ashworth score, which is used to rate muscle stiffness, of 2 or 3. So what does that mean? 2 means that there is marked increase in muscle tone through most of the range of motion, but the affected part is moved. And 3 is when there's considerable increase in muscle tone and passive movement is difficult. Note that these individuals were not contracted. Now, between T0 and T1, we gave the injection, and you see a reversal in the pattern. You have many more muscles or many more joints that are not stiff, showing a modified Ashworth scale of 0, and fewer that are stiff. And you see that at T2 and T3, which is 6 weeks after the injections and 3 months after the injections, you have the same pattern that persists. So the effect of treatment was persistent. This was published in Lancet eBiomedicine. And we also looked at range of motion at various joints. And you see that from T0 to T3, there's an increase in both passive and active range of motion, particularly when there wasn't sufficient range of motion in the beginning. Here's just an example of a patient who was getting Botox for several years. We're asking her to flex her wrist, and she really couldn't do it. She was stuck. However, 1 week after the injection, for the very first time, she's able to flex her wrist. And this persisted 2 months post-injection. You see that her wrist movements are much more fluid. In fact, she had fluid movements throughout the whole arm. We've seen this now repeatedly in another case series where the mean time since injury was 5.5 years. And you see there's improvement in passive range of motion shown in blue, as well as active range of motion. And what this slide shows you is that there is an additive effect of the injections. So the very first time you give the injections, there's some improvement, but when you give the injections the second time and the third time, there is additional improvement beyond the first injection. In other words, they may not come back to the baseline, which means we can promote recovery in both passive and active range of motion. The pros and cons are that, number one, it doesn't cause weakness. It can lead to improvement in neurologic function because active movement is potentiated. It's relatively inexpensive, and it has an excellent safety profile. The cons are that you do need to learn how to give these injections, and the drug is also not available worldwide. It's really only available in the United States at this time. We are currently conducting a randomized control trial, the very first one, in post-stroke upper limb muscle stiffness. And this is just a preview of what we are seeing. So here's a patient where we are doing range of motion. So you see the movement on the upper panel. And in the bottom panel, you're seeing hyperreflexia, or the response of the muscle to the stretch, to the movement. And you see at baseline, there's quite a lot of EMG activity. However, after treatment, you notice you're still moving the muscle, but there is a reduction in the muscle. So the muscle is quiet, suggesting that this hyperreflexia has been attenuated. Now here's another patient. Again, you're looking at the movements on the upper panel before the treatment. In the bottom panel, They don't have a very clear EMG response, but there is a low-level EMG activity, almost like a dystonia. And here too, after the injection, you see there's a reduction in this persistent low-level EMG activity. So to summarize, the muscles are the chief organ of neurologic disability, which is why early mobilization, early rehabilitation could be so helpful. Hyaluronan in the muscle can aggregate due to both paresis and immobility, as well as the neural hyperexcitability that results from the neurologic injury. Hyaluronan aggregation can lead to muscle stiffness and also pain and can further reduce movement. And focal treatment with the enzyme hyaluronidase may reduce muscle stiffness as well as muscle overactivity and potentially improve neurologic recovery. The clinical trials for these are ongoing, and I think there could be a lot of opportunity to do these trials in other parts of the world as well. We just published this textbook in October of last year, which goes over the mechanisms of muscle stiffness due to this and how it fits into what we already know about spasticity and the movement problems that arise in patients with stroke. I'd like to end by acknowledging members of my lab, the Motor Recovery Lab, my collaborators from across the world who have really helped provide the evidence behind this treatment, and the Hopkins team that is helping us conduct this first randomized controlled trial. Thank you very much for your attention, and I'll be happy to take any questions.
Thank you. Thank you, Dr. Preeti, for a nice presentation. Excellent review for the stroke recovery and the new modality of intervention and treatment. And I would like also to thank Dr. Muna Bahouth for the nice evidence for early stroke recovery and intervention and the importance of having a comprehensive rehab team with different members in that team. I would like to ask Dr. Victor Urrutia to start the Q&A, and I will advise all the attendees. We have a huge number there. So if anyone have questions, please put it in the Q&A box and we will start. Thank you, please.
Great. Thank you. And thank you to both of the speakers. Let me start with a few questions. There's a question for Dr. Mona Bahouth. One is that how many days or weeks would you recommend for stroke patients to be exposed to immersive technologies such as the MindPod, the video gaming?
Yeah, thank you for the question. I think the duration is really dependent on the patient's progress through their recovery. I think that assuring that the patient gets continuous interventions across the first few weeks is key without disruption. So that, if you're starting something in the hospital phase, you don't want to have a gap in the intervention treatments as the patient moves out of the hospital or to a next rehabilitation facility. But I think the duration will really be individualized based on the location of the stroke and the patient's progress over time. And once you get into the subacute and chronic phase, that will really be tested by the occupational therapy team, physical therapy team, and the physiatrist to prescribe the length of therapy for the patient.
Thank you. There's a question here for Dr. Raghavan. So is there a potential to use this treatment in children with perinatal stroke or cerebral palsy? Do you anticipate different responses in children based on understanding of mechanisms of muscle stiffness? And I would add a question that I was thinking that kind of relates to this, Preeti, is have you, I don't know if this is part of the design of your studies, but what is the timing for this? Do you wait? Is this just for chronic patients that are already stiff, or is there a role for prevention here? So,
yeah, thank you very much for those questions. So you can treat patients regardless of the actual etiology of the neurologic injury. So we are giving it off-label in children with cerebral palsy, in individuals with multiple sclerosis, with traumatic brain injury, even with individuals with ALS. And we are, writing for grants to do randomized controlled trials in many of these populations. The current trials, we have actually, the one that we are doing currently is on upper limb post-stroke. We have another one that we have NIH funding for actually myofascial pain post-stroke, so post-stroke shoulder pain. And I think there isn't potentially an opportunity to do it in other populations. And to your question, Dr. Urrutia, how early can you do it? You can give it as early as the stiffness is manifested. So we have given it to some individuals in the ICU. So for example, you could have a patient who's storming because they are, they are stiff, they're in pain. That leads to physiologic storming. It reinforces the pain. So we've given it in individuals with, say, traumatic brain injury who were not responsive to anything else. I just have, anecdotal information on those kinds of responses. We haven't done a study on it. So I hope that answers your question. Now, in terms of longevity, we've given it, for our studies, we're giving it between 4 months and 10 years post-stroke. We have given it afterwards as well in individuals who are more than 16, 20 years post-stroke, but we have to be careful that there isn't a contracture that's set in already.
okay, thank you. There's another question here, and I apologize for the previous participants that posed questions. I'm going to start mentioning the names. So there's a question here from Danielle Rodriguez for Dr. Bahouth. From your experience, what would be the main barriers for the adoption of immersive technologies as a consistent therapy method in a hyperacute or acute phase of stroke care?
I think any integration of technology can have some barriers. The technology itself needs to have electricity, and it needs to have a place that can be used by patients without a lot of change in position of the patient. So really easy access to the technology for the patient to use. You don't want staff to have to really do a lot of maneuvering of the patient for them to start using the technology. The other is to be sure that the technology is available to the patient across the continuum of care. So our team is really working to make sure that we have devices that can be used in the home as well as in the hospital, so that the patient can have continuity with that technology use. And then finally, using a technology that might be interesting to one patient and motivating to one patient certainly may not be for somebody else. So having an array of technologies available that might fit the person's clinical needs as well as motivation needs, that would be sort of the final frontier of barriers. But I think what we're really trying to achieve is a technology that's easy to use for patients, available where they are, and for use across their continuum of care as long as they're showing signs of improvement.
Great, thank you. So the next question is for Dr. Raghavan from Rodrigo Guerrero. And Preeti, you mentioned that you have to make sure the patient doesn't have a contracture. The question is, how can you make a distinction between muscle stiffness and a contracture in the daily practice?
Yeah, thank you for that question. That is important because very often we have seen that patients can look like they are contracted by physical exam, but when you can do ultrasound on the muscle and try to distinguish between stiffness and contracture. So when there is hyaluronic acid accumulation, it binds to water and it actually makes the muscle look dark, hypoechoic. Whereas if the muscle is contracted, it looks hyperechoic, where the muscle fiber, which is replaced by just fibrosis or collagen, is more white on ultrasound. It's hyperechoic. So there is a scale, a clinical scale called the Heckmeth scale, which can be used clinically to distinguish between stiffness and contracture. And in some cases where it's really hard to know, that's what we use. And if the muscle looks dark rather than white, then we've seen good results with these injections.
Great, thank you. Two questions that are related for Dr. Bahouth from Mohammed Ksar. Do you think that there's an ideal head position for patients with acute stroke? And also, what is the blood pressure targets that put a limit on the early physiotherapy?
Yeah, those are challenging questions. The blood pressure target for each patient might be slightly different. And the variables might include the type of stroke that the patient is having. Is this a large artery occlusion? What was the patient's set blood pressure before their stroke? Are they used to a blood pressure that's extremely high as their baseline? So the neurology team, the team that's managing the patient, the doctor could really prescribe what they believe the individual set point is for a certain patient. I would then recommend that activity is titrated to that set point by the individual doctor, who takes into account the patient's baseline blood pressure status, what type of stroke the patient is having, and whether the patient shows neurologic fluctuations with any change of position. And then to your next question about head position, there have been several studies that have looked to see what ideal head positions are for patients. The head post study using transcranial Doppler. So there have been studies to suggest that patients can tolerate change in position, but again, it depends on the type of stroke that the patient is having, whether there is blood vessel stenosis, and sort of what their underlying issues are. So to meet both of those questions, that's why we really have moved towards this progressive verticalization algorithm. We don't take a patient from the laying position to the standing position. We'll check them for orthostatic hypotension when we change positions. If they show signs of neurological fluctuation, we will use that verticalization table that slowly raises the patient up to be sure that they're not reducing their blood pressure too quickly for their own cerebral perfusion. So really great question, and right at the crux of what I think should be monitored very closely when prescribing activity in the first days and weeks after stroke.
Excellent, thank you. There's a couple of related questions for Dr. Raghavan. First, you mentioned that there was a difference between contraction and rigidity and stiffness in the patient, and you can tell that clinically. So Fatima Said asks if a patient with a stroke over 10 years ago presenting with stiffness in both left upper and lower limbs, can the patient benefit from these injections? And I suppose the answer is going to be that you have to determine that perhaps with ultrasound. But I'll let you answer that a little more. Now, let me just mention the other related questions. This is from Vinod Patel. Is the injection technique for hyaluronidase similar to the botulinum injection? And the other question is, what is the dose that is used?
Yeah. So in terms of the 10 years post, as Dr. Urrutia answered, the answer is usually yes, but you'd have to verify that. The technique is very different from that of Botox injections. In Botox, you're trying to inject only the needed amount of drug into the muscle belly where the nerve enters the muscle so that you can be very specific in your target. Here, you're trying to target wherever the hyaluronic acid accumulates, and it's not enough to inject just one muscle. You have to, so the hyaluronic acid typically accumulates at the musculotendinous junction. And it could be throughout the muscle as well. It depends on how stiff the individual is. But if you only treat the one muscle, you won't really be able to improve joint movement. You want to treat the agonists, the antagonists, as well as the synergists, and you want to select the muscles based on how they move. Do the muscles promote movement in the sagittal plane, in the frontal plane, or in the horizontal plane? So the technique is quite different, and that's why it requires some training. The dose can also vary greatly. It depends on whether you're giving it in children or in adults. More importantly, we don't use the commercially available concentration. We dilute it further. And how much you dilute it depends on the size of the muscle, the size of the patient, the degree of stiffness, as well as how quickly you want the action. So for example, if patients are using stiffness as a substitute for weakness for the lower limbs, you want to be much more careful, because even though the muscle does not cause weakness, it will get rid of the stiffness that is supporting them. So the same precautions that we use, when we give Botox for the lower limb are applicable here, but the mechanism is very different.
Thank you. And a question for Dr. Bahouth from Susana Guerrero. So the question is, for mobility interventions in the hyperacute phase and the acute phase, from the studies that you've done, what is the ideal patient-nurse therapy ratio considered? And just thinking about staffing as a worldwide challenge, what do you think they should consider in those cases?
Yeah, staffing is definitely one of the factors that may be an obstacle to having patients with increased activity. So when you're thinking about staffing ratios in terms of moving the patients frequently enough, it really depends on the responsibilities of those other staff members. So nursing ratios may be very high in some units. And that's why we really have been moving towards technology-based interventions so that we can reduce staff burden, but yet increase patient activity, meaning that the patient may be able, with their loved one, to activate these games to start their own activity programs without additional staff members. And so it's a perfect question. We've really been making sure that most of our intervention studies have not increased our required staffing ratios. For example, our progressive algorithm did not require any additional staff members. We're creating the operations manual for the video games to be able to be managed by patients or their family members. So really, we have staffing in mind so that we're sure that these interventions can reach people worldwide where we know staffing can be a major challenge.
Great. Thank you very much. I think that we've reached the end of our time. Is that correct, Suhail?
Yes, still we have 3 minutes more. So if you would like to give one questions to each speaker.
Okay, so
just to tell Mona and Preeti, this is very interesting topic in Middle East. Many people are looking for a rehab. Last year, we got many requests from our members to focus on this area. So thanks for Victor to get 2 distinguished speakers today. Please go ahead.
Okay, so for Dr. Raghavan from Emad Eldin Asa, what complications have been reported with using hyaluronidase injections, and what contraindications might there be aside from what you established already, which is a contracture?
Yeah. So the main potential complication is an allergic reaction because the enzyme is a protein. So we do a skin test before we give the intramuscular injection. You can just put a little bit of hyaluronidase under the skin, wait, just like any other allergy test. It's rare because this is what we are using is human recombinant hyaluronidase. The animal versions have been known to cause allergies. Other than that, the complications might be injection related, so muscle soreness, hematoma. If you accidentally inject it into the blood vessel, it gets inactivated. So you waste muscle, you waste medicine, but you don't actually it doesn't lead to weakness or complications in the rest of the body. So those are the chief ones, and it does not produce muscle weakness.
Great, thanks. And the last one for Dr. Bahouth, Omar Tawfiq asks, how many days on average does a stroke patient stay in the hospital? And I think that I'll add to that question. What is your view of the transition period from the hospital to the outpatient, Mona?
Yeah, I think, worldwide, there's been a focus on really decreasing the amount of time a patient spends in the hospital. So for ischemic stroke, say, we may have a 5-day length of stay for patients. Patients with intracerebral hemorrhage may have longer length of stay. And therefore, we really have been focusing on that transition period because patients have had life-changing condition related to their stroke. They may not be speaking, they may not be moving properly, yet we're sending more patients home. So I think to Dr. Urrutia's point, these transition programs are equally important to be sure that patients who may have stayed in the hospital for weeks previously, who are now leaving within days from their stroke, have enough support both emotionally, physically, and with all their medical comorbid conditions. So I think worldwide, we're trying to reduce the length of hospital stay, but all these interventions that we're coming up with are intended to follow the patient where they go from the hospital to their homes in many cases.
Great, thank you.
Thank you, Victor. Thank you, Dr. Mona. Thank you, Dr. Preeti, for a nice presentation. It's an honor to have both of you today. I would like to thank Sheikh Khalifa Stroke Institute and John Hopkins for being with us tonight. And I would like also to thank our attendees. We had a great number of participants today. There will be 2 CME hours, which we'll send to all registered attendees today, and hope to see you next month with another speakers and a new topics in stroke. Thanks for your presentation, both for speakers, and thanks, Victor, for your support.